Hello, welcome to week 3 of the evaluation and treatment of auditory processing disorders. During this week, we're going to go further into decisions that are necessary regarding scheduling and evaluation, factors affecting evaluation process, and then start discussing 2 out of 5 of the different AP skills that we're going to evaluate and look at tests that we will use during that process. The last 2 weeks, we've talked about screening and case history, ways to sort of triage a patient to decide whether or not we're going to move forward with an evaluation. There are some factors that we need to consider before we would schedule testing for APD. Number 1 is the age of the child. Typically, we're not going to do diagnostic on a child until age 7, although we can screen down to age 4. We certainly need to be able to access case history information and interview parents for medical history. We need to know or rule out whether it is prior to the eval or during the eval, normal peripheral hearing. We need to know if there are any language or articulation errors during the testing. The student often has to repeat words. There are picture pointing tests that you can use if articulation is possibly going to be a factor, but we need to make sure that they are verbal enough to be able to repeat words and that we can understand them. Certainly you want, if a child has been diagnosed with attention deficit and currently takes medication for that condition, you want them to take medication for the test because you're trying to control for as many other comorbid conditions, and we want to improve their focus and retention of information as much as possible. We are assuming that auditory processing skills are being evaluated in light of normal cognitive skills, and we talked last week about the difference between verbal and performance IQ, but we're essentially considering that the child has normal cognitive skills. If there's concern for that, then possibly we want to do IQ testing or a psychoeducational eval prior to the auditory processing. And then auditory processing is definitely a multidisciplinary disorder, meaning prior to an eval, we need to consider the teacher, speech pathologist, other school-based personnel, if there's an ENT involved, parents, any other therapists, counselors, psychologists that might be involved in the child. So I've said before that as an audiologist, you can evaluate the hearing mechanism all by itself. We don't need to talk to another professional to do that. But when you get past the ear into the brain, things are not nearly as clear-cut as it is with the ear. And we definitely need to include a large realm of people, if necessary, to make sure that we are accounting for all the other issues. So the other reason or other factor we need to consider is we need to make sure that the evaluation is going to add valuable options or improvements for that student. And I've mentioned that this can be the case in light of a peripheral hearing loss. There are many children with peripheral hearing loss that we suspect have an underlying processing disorder that's making things more difficult, meaning they don't benefit from hearing aids as much as we would expect based on the degree of hearing loss. And often I will ask, what are you currently doing with your student as far as remediation? If you have hearing aids and FM systems and are doing private and individual speech therapy and language therapy and doing a lot of auditory training, certainly evaluating for auditory processing and ruling it out or ruling it in can be an important part of why we would evaluate, but we may not be able to add anything new as far as an intervention or toolkit to help that student. And then, is the child capable of participating? As I mentioned, the student has to be able to repeat words or picture point. Is articulation an issue? Are they verbal enough? Do they have enough language? Can they understand the instructions when we ask them to repeat words or numbers? Are they able to do that from a language perspective? And then, is there enough evidence to evaluate for auditory processing? If symptoms and behaviors are consistent with attention deficit more than they are auditory processing, have we been evaluated for that first? Or is there another piece that we need to look at, like IQ testing prior to auditory processing? So based on the information you're provided, is there enough evidence to say there's difficulty. I've had many parents over the years that call and say, well, my child's having reading comprehension issues. And when I ask, do they have trouble following auditory directions? No. Do they have difficulty hearing in background noise? No. Then certainly, we want to look at that reading comprehension and what might be causing that, but there's not enough evidence or behaviors in the auditory realm that an evaluation for APD would be warranted. So we need to ask those questions when we move forward with an evaluation to make sure that we're going to be able to add valuable information to help that student. And so when we look at what type of testing we want to do for auditory processing, one thing that the ASHA task force and the AAA guidelines suggested is that we have to evaluate all the skills that we can. So you don't want to make a diagnosis of APD with only one test. In addition, in order to look at each of the 5 skills we've discussed, in order to say there's an auditory processing deficit, for example, in the realm of auditory closure or temporal processing, you have to have 2 tests in every category, and both of them need to be disordered or negative enough, or the score needs to be low enough. You don't want to just use one test in each of the categories to say there's a diagnosis. Furthermore, same thing with the normals. In order to say that a skill is normal, we want to do 2 tests. So there are a few parameters in terms of what tests we're going to choose. Are they age appropriate? For example, in your temporal processing, the duration pattern is normed on 9-year-olds or above. Typically, a student under 9 cannot understand the mechanics or the language, understanding the language meaning of short, long, short versus high, low, high. And so there are definitely language issues that you want to make sure are appropriate in the tests. And then one of the controversies of auditory processing is that we use words and sentences. So are we really just tapping into language skills, or are we tapping into auditory? And so it's helpful as one of those 2 tests in each of the categories that we use a test that has as minimal language content as possible. So numbers have a very low linguistic content. Numbers essentially don't light up the left hemisphere, so we want to use numbers. You can also use tones, where the student is just listening to tones instead of having to repeat words. So to minimize that linguistic load in one of the tests is helpful. Now, in saying that, in tests of auditory closure, there is no test that does not have have language content. We use words and sentences. So there's not a test in that category that we can use. So, but if there is, we want to include that also in the test profile. And you also want to look at the norms on the test, make sure that they are appropriate for your age. For example, there's an NU6 filtered word list that is very popular to use, but it was normed on veterans and adults. So it's not one that I use because I need one normed on children if I'm going to be testing children. So you do have to do a little research on the test that you're going to be using in terms of the age of the norms, the validity of them, and as we talk about sensitivity and are they specific to the disorder. So we want to make sure that we're careful with that. There are some tests that are very valid, have a long history of being a very solid test. The SSW is one of them. For auditory processing, dichotic digits is another. And so realistically, I give dichotic digits on every student because it's a low linguistic content test. It's easy to administer. I have norms on children down to 5. And it gives me one test easily of binaural integration. So it's not that you're not going to use, similar tests for similar students, but depending on the age and the response level, I'm going to pick what I'm doing. The test also can be a little dynamic, meaning it wants to be based on the reported difficulties. So if I have a student that comes to me and I suspect they're a temporal processing kid because they are slow processors, meaning it takes longer for information to go up from the ear to the brain, and they have slow responses. They might be slow readers, slow writers. In that situation, I'm going to start with my temporal processing tests because I want to get the student when they're as fresh as possible and as focused as possible, knowing that that might be a difficult skill and a difficult test for them to do, and I want to capture that at the beginning. So the testing can be very dynamic. If I start with one skill and I get a normal on one test, I might jump and do one test in each category to make sure that I'm capturing any disordered test, and then go back and confirm after. So there's some different ways to do it depending on the patient's age and their focus. The testing typically is scheduled for 2 hours, at least in my clinic, and I do go over the results with the family at the end. I do a lot of screening and triage prior, so I don't do a lot of interviewing during the eval. We usually just jump in and get started with the testing. In that 2 hours, I'm giving lots of breaks. So after two typical tests, I'll give the student a break, have them go into my other room in the office and play, or I have a big wipe off board wall, let them draw pictures or play some of the games I have, just to give them a break, walk around the building, just to make it not 2 hours or an hour and a half of solid listening. And then certainly in this, they're talking about the ways that a test is evaluated. There are several different ways that can be done. One of the most popular is the clinical decision analysis. And again, you're not going to do this, go through all of this on every test, but you are going to do a little research to make sure that the test that you are giving is one that has strong norms, a good reputation, is known to be sensitive, specific to the eval, so you don't get inaccurate results. So there are, again, some that you are going to use consistently with every student because of that. And it talks about a test being specific and sensitive, and the combination of those two is really what they call the efficiency, meaning is the test one that I can give in the shortest amount of time to capture a valid disorder if it's there, or rule it out if it's not. And so is that test one that I can give that's going to give me that information as easily as possible? And then typically you're going to use recorded measures for testing. Auditech is a company that will make you a custom CD, so I can give them, I have an adult version of Auditech testing and I have a pediatric. So my tests that are normed with peds, I have on one CD and then on another. And then certainly as things go to computer-based audiometry, you can save those files on computers instead of being on a CD, whatever, or a flash drive, whatever you want to do. So you definitely want them to be recorded to maintain consistency and accuracy. And then it's very important when you look at the evaluation process that if you identify an auditory processing weakness in your report, that you link that to the reported behavior. So if there is an auditory closure deficit, meaning the student has difficulty filling in the blanks of what they don't hear clearly, and they report that in poor acoustic environments like the gymnasium or cafeteria, they really struggle more than they do otherwise, it's important to say that may be why, that children with auditory closure deficits will have difficulty in poor acoustic environments, to link the behaviors with the testing. And then as far as the presentation level, typically it's done at an MCL level, and it's usually when I do quiet word rec scores on every student as a way to screen for a tick as well. But as long as I know that that's a comfortable level, then I will give that. I often ask the student, do they want my voice to go higher in volume or lower, louder or softer, just to get a comfort level to that. And it is important that you are not doing a 20 dBSL over thresholds, that it needs to be at a level that is mimicking conversational speech. So you want it to be a high enough level. And then in the interpretation of the auditory processing skills and testing, it's very important that you are comfortable in reporting qualitative data or clinical observations. So the example I give is that if a student is repeating words in, say, an auditory closure filtered words test, And for the next 3, where the student's supposed to listen and repeat, the student is saying, "Are we done yet?" Certainly that stimuli number 16 is going to be wrong because the student didn't repeat it clearly, but it's not because they misheard it, it's because they were talking. And so it's very important that you either go back and re-instruct and try again, or you note in your report that this is likely a low estimate because of the 6 errors, Johnny was talking through 3 of them, which suggests that it's not due to auditory processing, but more to impulsivity and possibly attention deficit. And it's okay to say that. There have been many times where I've said the tests, are not valid for this test and we need to look at another one, or put that in my interpretation. So we need to make sure that we are not just caught, making things wrong and saying that's an auditory processing deficit, but observing and documenting what the student's doing, and make sure it's not because they're mishearing, but because of something else. The other challenge and controversy about auditory processing is there's no great way to quantify the severity of the disorder. So in our peripheral hearing loss, we have mild, moderate, severe to profound. Pretty much we would agree probably within less than 5 dB, which category is what, if we had a pure tone average. But in auditory processing, you don't have that because you have to be very careful and make sure that all the other areas, possible skill areas, are affected. So if the IQ scores are low and you have low auditory processing scores, are they commensurate with where their IQ is? That may be that there's not a deficit in their auditory processing skills. And so you have to look at all of those issues. And so it's not as easy to say it's mild, moderate, severe. We certainly have levels of standard scores and -1, -2 standard deviations below the norm to say it's mild, moderate, severe. I think it also needs to factor in what an impact it's having on the disorder. So often I will say there is an auditory processing disorder considered mild based on the fact that these few reported behaviors may be due to the auditory processing deficit, but the behaviors and difficulties the student is experiencing in the non-auditory modality, and it's typically due to attention deficit, forgetting assignments and impulsive talking and decreased focus, is likely more of a significant contributing factor. So I'm going to make the auditory processing not the primary driver for that student. Not that we don't want to do some things and monitor it and accommodate and do any treatment we can, but I want to make sure we're not missing something that may be more of a significant factor. So of the 5 skills that we've talked about, making sure that we want to evaluate, we're going to talk next about binaural interaction and auditory closure. I start with these 2 because binaural interaction, it occurs right at the brainstem level beyond the ear. And so as we go up sort of the brain pathway, we're going to start at the lowest level. Auditory closure is done in one ear at a time. So it's a diotic, D-I-O-T-I-C presentation, meaning we're doing the right ear alone and the left ear alone. And so we're still at not to the cortex level where we're doing interhemispheric transfers. So these are the 2 lowest neurological areas. So auditory closure, again, is the closest skill to auditory discrimination. And the tests that we use to evaluate this are called mono or low redundancy tests. And in the literature, you'll see it referred to as MLRS. Auditory closure is the inability to fill in the blanks of what you don't hear clearly. So in the example of a student, do they hear cat for cat? They might hear ca and not get the T at the end. And so they're trying to fill in what that might be. The other one is binaural interaction, which is localization and lateralization, the ability to tell where in space and in the room sound is coming from. So they consistently are looking around trying to determine who's talking. And as I cautioned before, that also can be due to unilateral hearing loss. So in that situation, it's another reason why it's very important to always do a peripheral hearing screen. Even if a student has had a hearing test a week ago at another audiologist's office, if I see them for AP testing, I will always do a screening for pure tones and quiet word rec before I start, because you never know middle ear wise, what could creep up on you. And just with children and sometimes being difficult to test, I want to make sure that peripheral hearing is normal and that I am documenting that on that day. So when we talk about auditory closure, and again, the MLRS testing, what we're doing in these tests is we are taking the word or the sentence and we are modifying it by changing the speech signal by either frequency, intensity, or temporal timing features. So we're going to change the word somehow by filtering it or speeding it up or putting it in background noise so that they're not going to access it 100% of what the stimuli is. This is the one category of AP testing that does not have a non-linguistic stimuli to it. So it's all words and sentences. And this is due to this skill requires what they call extrinsic redundancy and then also intrinsic redundancy. And so because the signal throughout the brain has repeated representations throughout different areas of the brain, that's called the intrinsic. And extrinsic has to do more with the acoustics of the room, the background noise, more as how the signal gets to you, where intrinsic has to do with more what happens inside the brain. So some of the tests in this category are filtered speech, and typically you're using a filtered cutoff of 1,000 hertz, where the low pass information comes through, but they filter off the high pass. Research says you don't want to go really below 1,000 hertz. It becomes very difficult and is not realistic to test. Everyone's going to have difficulty the lower the frequency cutoff is. And then time compressed speech is done with sentences. And typically they have a 40 or 60% time compression, meaning the sentence is said very rapidly and they have to repeat the sentence and capture the words in there. And they also have compressed speech with reverberation that mimics a reverberant room, like a gymnasium or church. And a lot of times in different work settings, if someone works in a warehouse or a big room, I will give the reverberation instead of the time compressed to try to tap into that. The next one is called the SSI, which is the Synthetic Sentence Identification Test. And for this skill, you're going to do it with the ICM, which is ipsilateral competing message, meaning the signal and the background noise are in the same ear. And what this test does is it has 10 nonsense sentences on a card, and the stimuli is that the person on the recording will repeat one of the sentences. And the sentences don't make sense, so they really do have to hear it, and they have to be able to read. So again, you're looking at, can the participant read and see? And so we're looking at, can they identify which sentences is. They don't have to repeat the sentence, they just say the number that it is. And that's done with competing noise in the same ear. And then speech and noise is in this category. There are filtered words that are a better, more sensitive test or more efficient test. But there are some auditory figure ground tests. And one of the reasons I will give that is, in particular, if filtered words and, say, a time compressed or reverberant sentence test is normal, but the student, I suspect, has attention deficit, I will do a figure ground test or speech and noise, because that can be an indicator of attention deficit in light of other normal auditory closure tests. Again, these are other different ones in that area. And then when we talk about binaural interaction, I said it is dyadic. And so the listener is going to get information to both ears, and they have to combine the information. And so it is, there are several, or 2 or 3 tests that can be given. Binaural fusion, spondee fusion is another one, and then MLD, masking level difference, is probably the most commonly used. It tends to be the most efficient, and it can be given easily. It also has no words in it, so it's tones. They have to hear tones in and out of phase of background noise. So all they have to do is raise their hand when they hear a tone. So again, a low linguistic content on the MLD, and that's why it is more commonly given. So there's the RASP, the rapidly alternating speech perception, which is not used clinically very often. Binaural fusion, such as spondiffusion, is one that's commonly given, and then masking level difference is one that's given as well. And so these are some of the tests in that category. I did mention that binaural interaction is very, it's not common for auditory processing. So often I will do one test of binaural interaction, and if it's normal, I move on right away to the others because it's likely the others are going to be affected. And if I find a deficit in another area, I may or may not finish up a second test in this, because in all the years I've done this, I've only had 2 patients that had this, or 3 that had this difficulty. One was a patient with MS, which makes sense because it's at the brainstem level, sometimes is where they are affected, and 2 were veterans with known brainstem lesions. The rest of them have all been normal, so it's just not something I feel like I need to focus on as much. And then this is just some notes on MLD research and otitis media. And next week we will go on and talk about the other 3 categories of testing and electrophysiology to finish up the actual tests.